All right, everybody, we are back. Thank you so much. And as Dr. Zuckerberg was talking about during this technology hour, Dr. Zuckerberg, looks like we have our first guest from Retrace.
Hey, Vasant.
Hi, everybody.
Nice to see you, Vasant.
Hi, everybody. Can you hear me well?
Absolutely.
Yes, we can.
Yes.
Great, wonderful. Okay, well, thank you so much for having me here. I'm really delighted that I'm given the opportunity to speak at this event. I think that what you're doing is really nice, and we believe very strongly in this mission. So what we do, essentially, my role now is to do automated mental solutions primarily for images, right? But my background is in radiation oncology. I did a residency at UCSF in radiation oncology physics. I was also faculty there teaching various techniques for imaging head and neck cancer, oral cancer, a bunch of different treatment modalities as well. So the nice thing about dentistry is when I transitioned towards that field, you notice there's a lot of really nice anatomical information that's captured routinely. Even in CBCTs, you can see that, hey, maybe they're taking it for orthodontic purposes or other purposes, planning an implant, for instance. But they oftentimes take the image all the way up into the brainstem, into the upper brainstem, and way down to the lower cervical region, right? So we noticed that, hey, there's just a lot of great anatomy in here. We might as well maximize that. The difficulty of the human's face when they're looking at especially things in 3D on a CT scan, they have to go slice through everything, and it's quite laborious. Also, they're looking for a needle in a haystack, and it's not the most optimal imaging modality to detect that, but there is useful imaging content in there. And so the idea here is simply alert a doctor that there is a potential area of interest that perhaps they should palpate. They can't palpate it, or they don't have conclusive results from palpating it. They can escalate that. So that's the gist of why this meeting, I think, overlaps well with some of our core things that we focus on. Of course, primarily what we focus on is more conventional pathologies of the mouth, periodontal disease, caries, orthodontic information. But we feel that there's a lot of doubling up that can offer itself in killing several birds with one stone, so to speak. So that's the gist of everything that we do. What I know that the format of these is a little more conversational, so please, I'll go on, but please feel free to interject or expand on any portion of that.
Oh, so great. So first of all, thank you for coming on, and thank you for Retrace sponsoring our event today. We really appreciate that.
Absolutely.
I mean, obviously the technology is pretty amazing that you guys are pioneering supplement dentists' own expertise in interpreting radiographs. I know when I first joined Retrace as an advisor, I was skeptical hearing that software could kind of replace or maybe even, match, or didn't even think about the possibility that it might even be a better diagnostic modality than what I could see on my own. And I remember saying, well, let me try this with one of my own x-rays. And I submitted an x-ray for them to have the software run through. It was an upper left canine tooth that I had done a deep carious lesion on my wife about 5 years ago, and placed a very deep composite with a pretty thick radiolucent base underneath it. So to the untrained eye, looking at the radiograph of this tooth, the base almost looks like there's a lot of recurrent decay under the existing filling that I placed. And I followed it for 4 or 5 years after the restoration was placed. So, everything was looking status quo to me, but the x-ray I submitted was pretty much in a vacuum, and the software had no idea, no baseline x-rays to compare against for over the 5-year period. When the software came back, or when the report came back to me, it said with something like a 90+% degree of reliability that the radiolucency under the filling was a base. So at that point, that opened my eyes to the reality that, hey, this is the tool that we as dentists can use, clearly. And so I'm excited that, in the future, obviously right now, we're looking at, this is the tool currently for dental pathologies and hard tissues like, as you said, caries, periodontal disease, bone loss, being able to help insurance companies analyze claims by having the software indicate like a dangerous restoration to tooth ratio that might indicate the tooth would be a good candidate for a full coverage restoration. But in the future, the software might actually be able to further differentiate items such as lesions and give us a little more insight into what might be going on. So that sounds really exciting to me.
Yeah, definitely. And you bring up several very important points. One is time series information. The other point that you touched on is having several modalities. Typically, when we think of AI, it falls into two giant umbrella categories. One is narrow AI, one is general AI. And narrow AI is something that you see day-to-day life with you dealing with your iPhone or dealing with suggestions that you have on Google. General AI would relate to combining all of this information. Some people have their own definitions of this, but how we kind of move a little bit further away towards this narrow AI approach is combining all those different modalities. And this is really the way the humans would do it. I know when we first set off on labeling all of the types of data, so for folks that are not super hands-on in AI and do this every day, all day, it takes quite a bit of labeled data, especially for the image analytics component. So you have to have doctors in there, dentists in our case, and all this content. And one thing that was very clearly evident for us is that you need to have, it really helps them a lot if they have multiple imaging modalities and time series information. So we allow them to label that information, take into consideration previous FMXs that were taken, CBCTs that were taken, panoramic information that was taken, intraoral information that was taken, and we corroborate all that information together. We have our special novel ways of combining all that content. As you know, CBCTs might not be taken the same day or in the same month as all these other imaging modalities. And so we have a way of factoring that in. So it moves a little bit further away towards that narrow AI approach. And yeah, we've spent many years having these folks label this the data. We have our own our whole data labeling ecosystem. In the self-driving car, wanted to initially, they were very hopeful that you could simply feed in images of folks driving. And then when they were making mistake driving, that would be when there was an accident. So they would have that data as feedback. That turned out to not work at all. And so they had to set out all of them individually to make virtual environments, to have tons of people label imaging scenes, say this is a tree, this is a car, this is a human. So we have to do the same thing. When a dentist looks at anatomy of the mouth, they have an understanding of all these things and they make all these without realizing it.
Right.
You say, hey, we're just gonna, for one, we're gonna count teeth. Two, we're gonna see if we can see the gingival margin, if it is present. If it's not, we can kind of infer that information from other spatial relationships. We're gonna look at how far down will this probe go to estimate periodontal disease, or if there is a carious lesion. Hey, is this carious lesion along the field of view, meaning that maybe it's like a deep lesion along how you're viewing it from the X-ray, understanding of how that carious, that specific morphology would play out. Computers have to break things down into those subcomponents that as human, we just take this for granted. When we cross the street or when we analyze the world around us, we do so much of this stuff automatically. A computer cannot do it automatically. You have to tell this all the little specific pieces in the mouth, what it is, the extent of it, and so it can form those relationships for itself. That being said, there are certain things that computers do even better than humans, and it might just be a function of we just do it more than humans. For instance, humans are great at identifying car, identifying human on the road, a pedestrian on the road, no problem with that at all. But converting, let's say, someone speaking, just lip reading to text might be difficult for you because we haven't been doing that since we were children. We always have the audio. Most of us want to have the audio of that. And likewise, at distance, we can analyze kind of perceptually in our head. If we want to judge how tall a man is at distance, we would compare them against a window, against some sort of other seen objects, road, street, cars, other people perhaps, and we would then estimate that the height of that man at distance. Well, we do a similar thing in dentistry. Some of the diseases relate to absolute distances, such as in a periodontal case, or some of them relate to volumetric measurements in Carrie's case. And so we are good at estimating these things, but we don't have any absolute ground truth. So we kind of have to form this opinion or best estimation of what these different measurements would be based off of the X-ray image. And the advantage that computers have is we have a way of enriching that information, enriching that data content, so that we have those ground truths. So there's some fundamental advantages there. Also, what we have when dealing with cancer information, in some cases, we have the feedback from biopsy and other treatment. Obviously, if you know that the patient did undergo treatment, that would be a true positive. If the biopsy information revealed that there is in fact it's a cancerous tissue, that's what we call, and I don't like this terminology, but this is the shared terminology in this industry. It's called multidimensional labels. As opposed to if you were just to say based off of an X-ray or CBCT, you have three humans having consensus on it. Say, hey, that lesion looks like it's cancerous, and we say if there's consensus there, this is the way things are generally done when there's not that hardcore ground truth. So there's drawbacks to that. Dealing with breast cancer imaging, common, you would say, hey, is this pathology cancerous? And you don't have that ground truth data. You just have to rely on 2 out of 3 or 3 out of 5. But we have the advantage of dealing with that rock solid ground truth, which is really nice. Machines excel when you have that kind of information.
That is great. It's such a difficult problem to solve, and a lot of people, when they think of artificial intelligence, they probably have this vision of the software working independently without human intervention and just able to be better than us, or that you can actually teach a machine to look and read an X-ray. But the reality is there's a lot that goes into that. And thank you very much for explaining that all to us so eloquently. Appreciate it. Great.
Well, I noticed that my time slot was 10 minutes, but I'm happy to go on and expand on anything that you like. It's up to you, really.
It's fascinating stuff. So I would love to do that. I know, unfortunately, we're going to have Evan Turner come on from Bellscope next. But like Dr. Zuckerberg said, I just want to thank you. So, I've been saying this a lot, that there's been so much that companies are doing now to work with dental practices and ultimately to, help the patients. So such exciting stuff, and really appreciate you taking the time to come on today and sponsor the event.
Yeah, absolutely. Thank you so much for having me.
Thank you.